All right, folks, thanks so much for your patience and sorry about the wait here. Dr. Strings has yet to join us, but we're going to go ahead and proceed with our session, and we'll start with our case presentation first. So we'll just do it a little bit backwards today, but no worries. All right, so let's go ahead and start as we usually do, which is with a welcome. So first of all, thank you so much for joining us and welcome to our Health Equity Grand Rounds Echo. This is the second of our 6-part series exploring racism in medicine, health equity, and COVID-19 in Alaska. This echo is jointly provided by the Alaska Black Caucus and UAA Center for Human Development ECHO project, with support from grant funds awarded by the Municipality of Anchorage, Anchorage Health Department. My name is Erin, my pronouns are they, them, and I'm an ECHO coordinator with the Center for Human Development's ECHO project. I'd like to go ahead and invite Deanne Woodard from the ABC team to go ahead and open our session a bit by sharing, open our session by sharing a bit about the vision from the Alaska Black Caucus, which is driving this initiative. Deanne, over to you.
Hi, everyone. Thanks, Erin. As Erin mentioned, my name is Deanne Woodard, and I am serving as the program manager for the COVID-19 Community Fund Grant for the Alaska Black Caucus. The Alaska Black Caucus is the premier nonpartisan 501c3 nonprofit organization working to assert the constitutional rights of African Americans in Alaska. Recognizing that racism is a public health crisis, which was only amplified by the COVID-19 pandemic, the Alaska Black Caucus partnered with UAA's Project ECHO to deliver a Grand Round style health equity series. Grand rounds are historically a part of medical education in which clinical reasoning skills are enhanced under the guidance of expert clinicians. The Alaska Black Caucus wants to use this framework to create a forum for Black community members and experts in various fields to connect with healthcare providers, leaders, and trainees in order to address racism in medicine, disparities in COVID-19, and work towards our shared goal of health equity in Alaska. This project is one of many strategies that the Alaska Black Caucus is using to decrease racism-based health inequities in our state. Thank you for joining us for the second presentation in our series. We appreciate your participation and encourage you to engage fully with this presentation, as well as with all of our other work around health equity. Thank you.
Thank you so much, Deanne. All right, so participants, whether you've joined in on an ECHO before, it's important to know that engagement with the group is integral to the all teach, all learn philosophy that underpins our program. And we encourage everyone to ask questions and make comments during the session, either by coming off of mute when appropriate, or by sharing directly with the group, or by utilizing the chat box. You're also welcome to private chat the session host, which is myself, or our hub team, if you'd like your questions to be shared anonymously. We're also happy to offer CME, AMA, PRA Category I, and Nursing ANCC credits for our series. In order to claim these credits, you must, of course, attend our session and complete an evaluation, which will be linked at the chat at the end of today's event. Once you've completed the assessment, you'll be redirected to a JOT form where you can fill out and download your certificate of completion. This evening's session is on race-based medicine during the pandemic, how the COVID-19 pandemic has accentuated systemic racism in healthcare, and will feature a didactic presentation from Dr. Sabrina Strings, Associate Professor of Sociology and Chancellor's Fellow at UC Irvine, as well as a case presentation from our hub team and a Q&A session. A few Zoom reminders before we get started. If your internet does not support audio, you can join us by phone by calling the phone number we've entered into the chat box along with the meeting ID. Closed captions are automatically generated and available by selecting the CC icon at the bottom of your Zoom screen. We also invite you to take a moment to turn on your camera if you're able, so that we can all get to know each other a little bit better. The camera icon is on the lower left of your screen. And we do ask that you keep your microphone muted when during our presentations and when you're not speaking. You can mute and unmute yourself by selecting the microphone icon on the lower left of your screen, or by pressing *6 if you're calling in via phone. To help further build connections and foster participation throughout our ECHO, we do like to start each session with introductions. Hub team, as I call on you, if you could please introduce yourself with your name and pronouns, your role and organization, and a little bit about what drives your passion for health equity, that would be fantastic. Participants, feel free to share the same of yourselves in the chat box. And also, let us know what you hope to receive from this ECHO. All right, so let's go ahead and start with Ken, if you would, please.
Great. Good evening. I'm Ken McCoy, and it's an honor to be here with you tonight. My pronouns are he, him. I'm a recently retired chief of police and currently the chief diversity, equity, inclusion officer for Providence, Alaska. We all know that healthcare disparities impact people of color and other minority groups at alarming rates. We must focus on healthcare affordability, access, and the quality of treatment for all people. I'm hoping that through these conversations, we can identify the barriers and find solutions to bring true health equity to everyone. Thank you for having me.
Ken, thank you so much. And Maddie, if you would, please.
Hi, good evening, everyone. My name is Maddie Mandap. My pronouns are she, her. I am an integrated pharmacist at South Central Foundation Primary Care here on Denina land. I'm here because I'm passionate about health disparities. I'm sorry, my cat interrupted me. And I want to recognize our intersectional identities and ally with others towards this journey, in this journey towards health equity. Thank you.
Thanks so much, Maddie. Panna.
Good evening. My name is Panna Lynch-Jerusi. My pronouns are she, her. My role in this process is as an Alaska Black Caucus Hub team member supporting health equity grand rounds and this ECHO. And I'm here to learn and to grow. I am a school nurse with the Anchorage School District, having served 5 years at Fairview Elementary School and currently serving my 20th year at Robert Service High School. I also will be beginning my nurse doctoral journey in population health with Purdue University. And this has led me to a focus of operationalizing COVID health equity for BIPOC and marginalized populations within the Anchorage municipality. And this has fueled my passion for this journey in my work with the Alaska Black Caucus. Thank you.
Thank you, Panna. Obi.
Hey, good evening, everyone. My name is Obina Alu, but I do go by Obi. Pronouns he, him. Currently a pharmacist transitioning to a legal career or in the journey. And what drives my passion when it comes to health equity and health outcomes is I've been on the receiving and as well as the giving end. Being on the crossroads, I've seen how when it comes to people of color or minority groups, things such as health literacy, socioeconomic status, and availability and access to healthcare can truly impact outcomes, especially for marginalized communities, which is what drives my passion and is the reason why I'm excited and honored to be part of this.
Thanks so much, Obi. Allison.
Hey everyone, my name is Allison Horgan. I am a 4th year medical student at University of Washington in the Alaska WWAMI program. I am currently serving as the co-chair of the Alaska Black Caucus Health Committee, and I am so proud of the work that the Alaska Black Caucus does in the community and feel it is necessary both for our community and within my profession. And I'm just really happy to be here today. Thank you all.
Thanks so much, Allison. Jay.
Hello, everyone. My name is Jay. I'm the executive assistant for the Alaska Black Caucus, and I'm on my way to become a civil rights lawyer. So, I think it's very important to be the change that we want to see. And a key part of that is, addressing, these issues through conversations to bridge, these information and accountability gaps. So I'm just happy to be here and be a part of that.
Thank you so much, Jay. LaShonda.
Hi, I'm LaShonda McGowan, and perfect timing. I want to bounce off of what Jay said. I want to be part of the change. I want to be the change that I did not see as a person born and raised in Alaska. There was not a lot of Black representation. And so I want to, I am that. So, and I just want to continue to learn more and to grow, I guess, to be the best representation I can be. I'm here through the Alaska Black Caucus as a hub member. I'm a social worker and a clinician for Alaska Behavioral Health. And yeah, that's me.
All right, thank you so much, LaShonda. And thank you to the rest of our hub team for your introductions. All right, participants, and for your introductions as well. We thank you for sharing a bit about yourselves. All right, so a few final reminders before we get started. The opinions of our hub team and presenters are their own and do not necessarily represent those of the Alaska Black Caucus, UAA, the Municipality of Anchorage, Anchorage Health Department, or any ECHO sponsor. Additionally, Project ECHO is not HIPAA compliant. Therefore, we ask that no protected health information be shared or displayed at any time. And finally, I want to acknowledge that the subjects that we're discussing here today carry weight. And as we will explore during this series, racism and its impacts are not abstractions. They exist materially, bodily, emotionally, and spiritually. I invite those joining in on today's discussion to do so with that in consideration, to listen, to keep questions and comments on topic, to be considerate, and to use language that is respectful, especially when in response to those with lived experience and expertise. So thank you so much, folks, for following those guidelines. All right, we're going to go ahead and start with our case presentation, which was submitted anonymously and will be presented by one of our hub team members, Allison. All right, team, thanks so much for providing that case presentation. Let's go ahead and move on to our didactic presentation. Dr. Strings.
Hi, good evening.
Hi, welcome. Thanks so much for joining us. Great to have you. Let's go ahead and get started with a brief introduction, if you wouldn't mind, and then we can move into your presentation.
Yes, absolutely. Is someone else going to introduce me, or should I introduce myself?
Would you mind introducing yourself?
Sure.
Thanks.
I am Sabrina Strings. I am a Chancellor's Fellow and Associate Professor of Sociology at the University of California, Irvine.
Wonderful. Thanks so much, Dr. Strings. Dr. Strings will be providing our didactic presentation today. So without further ado, Dr. Strings, over to you for today's presentation.
Great, thank you. Let me just make sure I can share my screen. Okay, there it is. Let's see. A little bit. Okay.
Looks great.
Great, glad you can see it. So today we're going to be talking about the racial past and present of weight stigma. So just to give you a brief overview of what I'll be covering, I'm first going to tell you how I, as a straight-sized ally, came to this topic. I'll do a brief history of race, weight, and aesthetics. I'll describe how aesthetic ideals infiltrated medicine. And then we'll get to this question of the problems of BMI within the obesity epidemic. We'll also cover questions regarding fat and COVID. This is an image of a typical Black family that would have been moving to greener pastures during the Great Migration. The Great Migration lasted between approximately 1916 to about 1970. It was a time period in which for many Black Americans, they could finally leave the rural South and head to places like the Midwest, the Northeast, and later waves, the West Coast. My family, like many families, was a part of the Black migration, the Great Migration. My grandmother uprooted her family in 1960, traveling from the rural pastures of Georgia to sunny Los Angeles, California. When my grandmother was young, she picked cotton. In fact, my grandmother's grandmother was a slave. So this just goes to show you, first of all, the proximity of slavery, as well as how little progress had been made in the 2 generations thereafter. When she was young, she told me rather that when she was young, she once received a basket of oranges for Christmas, and it was one of her happiest memories. So that is to say, it wasn't as if there was an abundance of food lying around for Black people who had lived through the Great Migration. So you can imagine her surprise when she arrived in Los Angeles in 1960 and was living and working for the first time around white people. And she noticed that there were a number of white women on diets. So this is an image of some type of exercise regime for white women in the 1940s. And I've never been able to identify what any of these contraptions are, but I guess we can all rest assured that they were not effective. So my grandmother found this whole phenomenon curious. She was like, what's going on with this? So that by the middle of the 1990s, when I was a teenager, she would pull me into conversations about this. I remember once she was watching her favorite soaps, The Young and the Restless, and she rushed me into the living room. Sabrina, come here, take a look at this. And so I ran into the living room. I was like, what is it? And she was like, now look at Victoria. Victoria is a character in The Young and the Restless. This is a picture of Phyllis, a different character in The Young and the Restless, because I couldn't find an appropriate image of Victoria. She said, these white women are dying to be thin. Why are they dying to be thin? And being that I was a teenager, I was like, I don't know. I can't be worried about my grandmother's questions. I need to be focused on mastering the choreography to Brandy's I Want to Be Down. But I had a change of heart in my early 20s. Shortly after I had finished my bachelor's degree, I decided to take a job working at an HIV medication adherence clinic. And on one occasion, I was interviewing 2 different women, both women of color, about why they weren't taking their HIV meds. And both of them told me that they were afraid of gaining weight. And that was a mind-blowing revelation for me, because obviously, when you are considering whether or not to take your HIV meds, you're engaging a question of life and death. And so these women were willing to risk death in order to quote unquote maintain their figures. So at this time, I thought this is actually a much more expansive problem than we have realized. And I thought I would go back to school to investigate the origins of the thin ideal. So in my research, I found that, as many of you may already be aware, voluptuous and curvaceous physiques were prized during much of Western history. So here we have an image from the Renaissance master, Peter Paul Rubens, circa 1615. It's known as Venus in front of the mirror. And you will notice that Venus, who is supposed to be the neoclassical ideal of beauty, is represented as a rather curvaceous, voluptuous, bodacious woman. She is presenting her undulating curves for the viewer to admire. There's a little cherub holding up a mirror so that she might admire herself at the same time. And you might even notice that there is a small and slender Black girl in the corner, known as a page or an attendant, who's also looking on longingly. So in this particular image, even though there is clearly a racial difference being affected, the difference is that white women are statuesque, and that is considered desirable. Black women were deemed to be too small and thin to be considered attractive, increasingly after about the time period in which this was painted, so throughout the 17th century. So what we know is that prior to the 18th century in the Western world, voluptuous physiques were prized. But in the tail end of the 17th century, something called race science was developed. Now, it was developed largely as a rationale for slavery. In fact, the man who invented the first racial classification schema, a man by the name of Francois Bernier, was intervening directly in conversations that were happening about whether or not they were quote unquote natural slaves. So these were the debates that were roiling in the 17th century in France. And so what he wanted to do was he wanted to suggest that, okay, there are different types of people who belong to different locations of the world. And these people are largely biologically distinct. These are the races of the world. Even though he doesn't mention weight in his original classification schema, there were many different racial scientific theories that were built up by the 18th century, which was the height of the slave trade in the Western world. And by the middle of the 18th century, there started to be this suggestion that Africans were, quote, greedy eaters. One of the reasons for that is that during the 18th century, we also had the Enlightenment, and Europeans were suggesting that they were the ones who were rational and controlled, and that they had some type of way of managing what was known as the animal appetites, those being sexuality and orality. They argued that Black people were hypersexual. They also argued that Black people were hyperoral. One such Enlightenment theorist, a Frenchman by the name of J.J. Verret, argued, Black people are those great eaters, intemperate epicures who seem to live only to eat. They have a stupid look, always digesting. They become incapable of thinking. So J.J. Verret was particularly interested in the so-called Hottentot peoples. These are the Khoisan people of South Africa, and they had been given the moniker Hottentot by the Dutch who colonized them. A lot had been written by first the Dutch and then later the English, who also colonized South Africa. And a lot of the things that were written were making their way back to various places in Western Europe, including, of course, France. So Verret, who never, of course, went to South Africa himself, had a lot to say based on things that he read. He argued that the Hottentot women develop big butts and bellies that push out. He said, the derrieres of Hottentot women resembled that of four-legged creatures, at times growing so large that they could be supported with a small cart, like a domesticated animal. And here, what he's doing is he's calling upon racial theories that were popular in the 17th century, known as the Great Chain of Being. This suggested that there was a line of descent from God to the lowest of animals. Of course, Europeans suggested that they were closest to God. They then argued that Africans were the closest to the lowest animals. So in this way, you can see that he's making some type of relationship here between Africanity and animality. Now, there was no one Hottentot individual who was more famous than the so-called Hottentot Venus, Saartjie Baartman, depicted here. Saartjie Baartman is also depicted here and here. So one thing that you might notice is that there was no consistency in her rendering. That's because she was, in fact, both an individual who lived and a tremendous myth in the hearts and minds of Europeans. They believed that she was a, quote, ideal or perfect specimen of Africanity. And part of the reason why they suggested this was so was because of her size and shape. There were people who argued that she was 3 yards and 3/4 round, as we can see here in this particular rendering. As it turns out that this representation of Saartjie Baartman is based on the plaster cast of her figure. So we can see that in fact, her dimensions were very different from the way that she was often depicted. But nevertheless, she had been working as what was known as an infirmary delight when she lived in South Africa. She was also enslaved there at the Cape. She was owned by a colored man. She was ultimately sold to a British entrepreneur who thought he could make a lot of money bringing her to the European mainland. So he put her on display, first in London and then in Paris. And when she was on display, European audiences came out by the droves because many had never seen a Black woman before with their own eyes. Keeping in mind that the way that the slave trade worked was that Black people were largely taken from Africa and brought to the colonies. They were rarely brought to the various bustling cities like London and Paris in Europe. So when she was put on display, she was often put behind a small enclosure, and the audience would be allowed to file in, not seeing her. At a certain point, Dunlop would alert her to come out and charge the crowd, which is what we see depicted here. And these urbane Europeans, having never seen a Black person before, were both shocked and titillated. Some of them looked away in horror. Some of them tried to get a better look. This is the quality of what we call negrophilia and negrophobia. These two things are always existing at the same time. There's the fear and the desire at once. Significantly, this is a real image from the 19th century, a period shortly after she would have been on display by a French artist named Sebastian Coeur. So given the reality that is depicted here, this is the reason why I chose this particular image of Sarchi for the cover of my book. Now, since Europeans were arguing that Africans were hypersexual and hyperoral and that they were restrained and controlled, you will notice that over time, they revised their own standards of beauty. No longer interested in the voluptuous Venus, excuse me, they were now looking for women who were much more restrained in their appearance. You will notice that this woman is quite demure. She's tight-lipped, she's fully clothed, she is extremely slender. This is an image from one of the most famous British artists of all time, Thomas Gainsborough, known as Mr. and Mrs. Andrews. This was taken during the height of the Enlightenment, or painted during the height of the Enlightenment. In this way, we can see how European women were being rendered by the middle of the 18th century as the antithesis of Black femininity. And you will notice that the way in which it is happening now has reversed in just over 100 years. Previously, they were voluptuous and Black women were slender. Now they were slender and Black women were, quote, too fat. So start with just a few key points before we move on. It's clear that fatness was once prized in the West. But the rise of slavery and race science led to the denigration of fatness as related to Blackness. It also led to the suggestion that white people were thin and that white people's beauty ideal should be the slender aesthetic. A lot of the ideas about European versus African beauty made their way to the United States through the medium of publication. Women's magazines in particular would refurbish ideas from racial scientific theories and place them within their magazines. They wanted to provide an understanding of what constituted proper behavior for women, but also proper appearance. So in Godey's Lady's Book, the most popular magazine for women of the 19th century, it was not uncommon to find quotes such as this: "The Anglo-Saxon race's women are taller and slenderer than were the Grecian females." So you notice here, they're making a direct comparison to the Venus. And if we may credit history, far more lovely. They also write, in some parts of Africa, no lady can be charming under 21 stone. So 21 stone is approximately 300 pounds. Okay, so you can understand that they were using the direct racialized language about what it meant to be an attractive woman in women's magazines in the 19th century. And in fact, it was quite effective. A lot of women took to the advice that was presented in these magazines, so much so that doctors took notice, including Dr. John Harvey Kellogg. And yes, it's the very same Kellogg of your favorite cereals. He, for one, thought that women's fashions were in large part responsible for this dramatic shift in Anglo-Saxon women's figures. He said, you know what? American Anglo-Saxon women have figures that are thin, flaccid, and powerless. he thought it would be very important for us to reform the figure of the average American woman in order to ensure the superiority of the Anglo-Saxon race. And so he set about writing books and articles about how women might be able to reform their figures such that they are powerful and strong, but nevertheless not obese, because too much fatness, as he was well aware, being a person who trafficked in eugenics, was related to African identity. And even though people don't often think of the contributions of someone like John Harvey Kellogg, he did publish in the Journal of the American Medical Association many times. He also published in AJPH about a dozen times. So he was an influential kind of guy. But there were others who published in JAMA, for example, who had similar ideas. One of whom was Morris Fishbein. He was the co-editor for the Journal of the American Medical Association. You can see that he wrote a book, Your Weight and How to Control It, a scientific guide to medical specialists and dietitians, okay, or biomedical specialists and dietitians. You can see it was written in 1929. And what they were trying to do, even here, was make a clear natural relationship between race and weight. So Morris Fishbein writes, the American girl is an end product of a mixture of races, predominantly Anglo-Saxon. She is usually somewhat thin, often rather angular. Okay. So there was an interesting kind of two-step that was taking place in this book, in which Morris Fishbein is partially trying to justify this notion that Anglo-Saxons are just inherently slim, but also trying to provide some advice for those women who were getting, again, too thin, according to doctors' understandings of how women should look and what they should weigh. So this kind of controversy surrounding women becoming too thin continued for a couple of decades. But by the 1960s, there started to be a shift in the understanding of what was taking place. More people started to become concerned about excess fatness, as it was known, and still is in many places. One such person is the man depicted here, Ancel Keys. So Ancel Keys had always been interested in the question of how little food a person needs to survive. You can see here that he had been conducting the Minnesota starvation study alongside efforts during World War II to determine appropriate rations. And so part of his impetus had long been to understand the minimum requirements for human survival. But not for nothing, Ancel Keys also had some rather, I suppose, eye-opening views on fatness. He believed that fatness was ugly, disgusting, and repugnant. He thought that fat people were clumsy and that their bodies were hard on furniture. And yet it is Ancel Keys who was one of the integral figures in making the move from what was known as standard weight tables, which were given to doctors by insurance companies as a mechanism of determining who should have insurance and what was considered to be a healthy weight. So Keys thought we should not get our dictates from insurance companies. We need to have our own understanding of the relationship between weight and health. So he wrote, quote, if not fully satisfactory, BMI is at least as good as any other relative weight index as an indicator of relative obesity. Not the strongest endorsement, but nevertheless, Keys and other powerful and prominent doctors were quite successful in lobbying the World Health Organization. And in 1995, the World Health Organization published a report on obesity using BMI, which is body mass index, which is a measure of the relationship between weight and height. It was based on a meta-analysis of 17 international studies. And the report suggested that there should be classifications of BMI that we are now familiar with, 25 for overweight, 30 for mildly obese, and 40 for what is often termed in the harshest sense of quote unquote morbid obesity. Now, significantly, the authors described these designations as, quote, arbitrary. But nevertheless, they decided to move forward. So you may be asking yourself, okay, maybe there was a rather unusual way in which BMI became adopted ultimately by the medical industry. But isn't an elevated BMI unhealthy? Let's review some of the problems with using BMI. First, as I've shown you, BMI is what's known as an eminence-based tool. It is not evidence-based. That is to say that it was adopted based largely on the advice of prominent doctors and not based on findings, because as we've already seen, they suggested that these categories were arbitrary, but decided to go forward with them anyway. The classificatory groups were created without relying on findings and input from a diverse and representative sample of Americans. This ends up being very important because of the fact that all of the doctors that I've been able to find who were involved with the creation of BMI categories were white, and most of them were white men. What we have is what's known as colorblind racism operating here, which is there's the assumption that white persons might be able to identify for a diverse slice of America or even the entire globe what constitutes the relationship between weight and health in the absence of studies conducted specifically to identify that relationship, right? And so in a way, we can see how this is very similar to the construction of race science in and of itself. There are some prominent Europeans making ideas about how people look and what their looks mean. And for a very long time, we've known that BMI is a troubling tool, right? There's a number of different reasons for that. It's a terrible measure of health, as we've seen in NPR and 538. And increasingly, schools of public health, like the one at UCLA, are advocating the end of the use of BMI. Now, I didn't put this on the list, but obviously one of the other problems with BMI is that it cannot measure adiposity or muscle mass, right? Only total weight. Evidently, adiposity and muscle mass end up being very important to determinations of whether or not a person can be considered quote unquote too fat. Now, finally, the over-reliance on BMI contributes to the stigmatization of fat people, which leads to worse health outcomes. Right? Something that has been long recognized by the Kaiser Health Network, the Harvard School of Medicine is also now becoming much more interested in the problem of weight bias within medicine and the role of BMI in contributing to weight bias. And even the World Health Organization is concerned about the role of obesity stigma. Okay? And in case it's not clear, there are many problems with obesity stigma. One of them is that, of course, if you are a person who is labeled obese and you know that you're going to go to the doctor and the first thing that they're going to tell you is to lose weight, you may simply not go to the doctor, which means diminished care for individuals deemed overweight or obese. There is also the possibility that they might engage in weight loss efforts, but people who lose weight overwhelmingly gain it back. And so this type of yo-yo dieting is actually far worse on your organs and especially your heart than simply being fat. Okay. And importantly, we know that racism and sexism are still at play in discussions of obesity. We know that if we rely on BMI, Black women have some of the highest BMIs in the country and are stigmatized and constantly told to lose weight as a result. And again, we're relying on a faulty tool. And so in this way, BMI contributes to the racism and sexism that undergird fat phobia generally. And of course, I'm sure you're all wondering, what about COVID? Now, we've all seen reports showing that individuals who are labeled obese using the measure of BMI have worse health outcomes with COVID. but I thought it would be interesting to take a look at a couple of things that might indicate something is amiss in these analyses. First, we have the countries here on the left that have the highest caseloads for COVID and also the highest death rates: United States, Brazil, India, Russia, Mexico. On the right, we have the world rankings in terms of obesity. So this is interesting, the way that these actually don't line up. We might notice that the US is 14 in the world. Brazil is 94. They have a quote obesity rate of only 19%, and yet they have some of the highest deaths from COVID. Mexico is 45. Russia is 95 on the list. And India has one of the lowest obesity rates in the world. So what can explain the fact that they are number 3 on the death list if obesity is supposed to be so predictive of COVID outcomes? And so now we get into some of the problems with relying simply on these correlative studies, because there's clearly something else going on with COVID that is not being addressed. So here I have a summation of some of the other vagaries. We know that Canada has about 1/9 of the population of the United States, an obesity rate of 30%, and only 24,000 deaths. New Zealand, a much smaller population than the US, but also 30% obesity, right? They only had 26 deaths. Whereas in the US, back in 2021, the US has an obesity rate of 42.4%. Okay, higher than those other two, but a staggering 572 deaths, 23 times the number of deaths in Canada and 22,000 times the number of deaths in New Zealand. Clearly, the weight is not the essential factor in death rates in the world. We further know that even though men and women have almost the exact same rates of obesity in the United States, men are about 50% more likely to die from COVID than women. Now, there have been studies that have been conducted since 2021 showing that, in fact, it's not BMI, but it's visceral fat that is associated with severe COVID-19 outcomes. And as you can see here in this study from Metabolism, visceral fat is associated with COVID-19 severity in Caucasian adults, not in other races. Okay. In another study, we find that there are substantial differences in COVID-19 infection and mortality rates between Asian and European populations, or between white Americans and African Americans. African Americans have the lowest visceral adiposity, right? However, mortality rates are the highest. So I'm presenting this information so that we can understand that it's very easy to claim that fat, and especially through BMI, is what's driving COVID outcomes. But that is clearly not the case. Additional studies are needed to be able to understand how it is that African Americans who have the lowest visceral adiposity are nevertheless having some of the worst outcomes with COVID. So to conclude, fat phobia is rooted in anti-Blackness. And since women are often judged based on their appearance, it has had a greater impact on Black women historically. BMI categories constitute an eminence-based form of medicine and also a form of colorblind racism. We know that fat stigma propels poor health outcomes. And also we know that with COVID-19, the real association is between visceral fat, not BMI, and poor outcomes. And that this association is actually the strongest for white persons and men. Conclude my comments there, and I'll look forward to your questions.
Thank you so much, Dr. Strings, for that really comprehensive and valuable presentation. I'd like to go ahead and invite participants to go ahead and share any questions, and also Hub Team, any thoughts for Dr. Strings?
Hey, Dr. Strings, thank you so much the presentation and all the information that you shared with us. I just want to reference some of the messages that came through in the chat while you were presenting and see if you had any comments or could expand on possibly any of these comments. So Courtney Ryan asks or states, those workout machines were supposed to help spread and loosen fat cells in the body. And that's followed by Dion, who further goes on to say Kellogg, or Dr. Kellogg was the same one that believed, I'm assuming epidurals were needed with every vaginal delivery. Not surprised by this thinking of the female body.
So did the person who mentioned the machines know the name of them? Because that's absolutely fascinating. As opposed to loosen and separate fat cells. Is that what she said?
Yeah, Courtney, if you're still on, would you like to unmute yourself and share a little bit about the information that you have on that?
I did a quick Google search because growing up, my grandmother had like some old school magazines from back in that time. And I just remember like looking through them and it kind of triggered a memory. And it was just, they had those, the shakers where you would sit there on like a treadmill like machine and they would shake to loosen everything. And that was kind of like the body image, you know, kind of like that you were talking about getting that hour-shaped glass. And then I was thinking of like the corsets and how that would get the hour-shaped glass for the women. And but just kind of like I see the commercials like in the area that I live in, there's a place called Sono Bello where they do these certain sections of fat shrinking cells and nowadays, and it kind of disperses and breaks up in the body. And those machines that you were showing are similar to that idea where they would try to loosen up and spread throughout the body so they could be thin and toned at the same time. But we obviously know that that doesn't work.
Wow. Okay. Fascinating.
I did have a question. In your research that you did you come across any eating disorders with the introduction of, you know, white Caucasians being, you know, anorexic or bulimia or, you know, any race really, but I was just curious about that.
I don't research eating disorders specifically, but I have found that eating disorders are growing in minoritized populations, in Black and Brown populations. Whereas before there had been a lot of conversation of what was happening with white women and girls, I think for obvious reasons, given the history that I've related. We also know that eating disorders are growing amongst men. According to some analyses, approximately 40% of individuals struggling with eating disorders are male. And these are things that are being underreported. So I would suggest that this, of course, can be yet another ramification of the type of fat stigma that exists in our society. People would much rather endanger themselves by avoiding food than, I suppose, endanger themselves by eating in a way that other people would shame them for.
Okay, yeah, no, that makes sense. I do agree that it's very underreported because I work as a social worker. I work with the majority of you know, African-American individuals, and you know, they have mentioned in time or two in the past that they've struggled with eating and eating habits based on how they grew up, whether it was lack of food, lack of income to buy food or appropriate food, and just resources in general. And they never, when we get to talk about, my specialty is not eating disorders, but I know enough to kind of guide them to get the proper help if they need it. But to talk about it and hear them say it out loud, it's almost like a switch goes off and it's like, oh, maybe I did at one point have the beginnings of an eating disorder and things like that. So thank you for that.
Great, thanks so much. It looks like we have another question that came across to me. And the question is, looks like they'd be interested in knowing what other systems exist or in development that would be a more accurate measure of unhealthy weight. I know you mentioned visceral fat, but aside from BMI, are there any other measures or systems that you know that would be a more accurate reflection?
I think visceral abdominal fat is our best measure. And I feel as if one of the ways in which that can help to reduce fat phobia is that anyone can have an accumulation of visceral abdominal fat. You don't have to be a particular weight. A person who might be identified as thin can also have an accumulation of visceral abdominal fat. So it's not the kind of thing where you look at a person and you make a judgment about their health. It's actually much more difficult to find out about visceral abdominal fat. I spoke to an epidemiologist who told me that the best chance that you have of doing that is by investigating cadavers. So it's not considered ideal by many, but I don't think that there's anything else in development to challenge BMI, but I would also say we don't really need anything else. The reality is that before BMI was instituted, we used a series of measures that were intended to judge if a person was maybe in the top 15%, for example, of weight in the United States. We use more holistic measures. And so there are a lot of people who are simply calling for us to remove BMI and go back to this more holistic way of assessing a person's health.
All right.
And raised by Panna.
Panna.
Yes, as a high school nurse, this is a powerful subject. Thank you, Dr. Sabrina. We are still mandated by the state of Alaska to do height weight as a screening tool for children through their high school tenure. And what I have always adopted is that the process of taking an adolescent's weight is an invasive procedure, and it doesn't really address the issue. So what I am seeing in your presentation is there's no discussion of nutrition, there's no discussion of lifestyle, and there's no discussion of exercise and positive image and positive holistic look at the person's body. But in my practice in high school, it is something I work with and fight all the time in all ethnic groups.
Thank you so much for your comments, Panna. I've come across that so many times in doing this work. I meet so many women usually who say, I eat healthy, I exercise, my heart health is amazing, doctors think I'm an anomaly. I mean, the very idea that we have this term obesity paradox, such that we could be surprised when a person is obese and healthy. It's like, well, that's only considered a paradox because we have an assumption that fat people should be unhealthy, and that assumption is rooted in evidence-based medicine. If we were to simply remove BMI as a tool, we wouldn't necessarily think it unusual that a person could be fat and healthy because of the fact that we would know, people have a variety of different reasons for being the way that they are. Genetics plays a tremendous role. And so we can't know by looking at a person what they eat, how often they exercise. Also, to the point, one thing that I try to keep people focused on is that when we look at an individual body, at one moment in time, we are not paying attention to all of the upstream factors that are much more important for causing health outcomes. We're not looking at whether or not they're food secure, if they live in a place with limited access to drinking water, like Flint, Michigan, clean drinking water. And we know that these types of contaminants actually work as irritants that inflame the stomach, right? And so an inflamed gut is an unhealthy gut, and it also contributes to weight gain. And so there are all of these other factors that are going on that we're ignoring that we should be addressing, like poverty, as we look simply at one individual and think, is their body too large?
Katie, I see your hand raised. Would you like to express your question or comment?
Yeah, I have to say thank you so much for this talk. I used to work as a clinical and outpatient dietitian, and this issue of BMI being a judgment on health is a problem I saw quite frequently, and especially when it came to people who are of larger size who had health issues, concerns, new pain, and often being dismissed that new pain or that problem was because of their size and not because of other health issues, which led to, misdiagnosis or delayed diagnosis of very serious health issues that could have been resolved much earlier and much easier had they been listened to. So thank you so much for bringing this up.
Thank you for those comments, Katie. And sometimes I present about instances just like that, because there have been instances that have been reported in the news of fat women going to the doctor says, lose weight. And what the doctor is actually missing is that they have cancer, which is, and so it's like, we are not paying attention to people's serious health issues because we're too focused on whether or not a person is weighing too much.
Yes, thank you so much, Dr. Strings. I wanted to point to a couple questions here in the chat, and Ken, I do see your hand raised. So let's go ahead and address this one first from Allison, who's asking Dr. Strings if you could speak to the role of Health at Every Size, the movement, in terms of a clinical practice or implementation strategy to address fat phobia. What are some tools that our participants can implement?
Yeah. I don't know. I don't actually work for Health at Every Size, although I am, I would suppose, an ally of the Hayes model. So I can simply speak to what I understand about it. To my understanding, Health at Every Size is one of the groups that is advocating for, the end of BMI, but also for the end of taking weight and using weight as a tool to assess the relationship between their symptoms and their actual health status. I know that many of the people who are doing this work are trying to encourage doctors to limit the very simple process of taking people's weights and then making recommendations. And so I'm in favor of the idea that what we need to do is, instead of focusing on trying to figure out how to get a person to look a particular way or be a particular size, try to give everyone tools and advice for how to lead healthy lives. And so a lot of what Hayes does, to my understanding, is offering advice on nutrition. I know that Marilyn Wan, who has been very active with Hayes for a very long time and author of the book Fat, so, writes a lot about this discovery of how, if she, instead of focusing on eating a small amount, focused on incorporating the right types of foods, she could feel much better in her body, because now she's not trying to train her body to do a thing. She's simply trying to make sure that no matter what she's eating, she's getting the sufficient nutrients that she needs. And so I know that for a lot of Hayes folks, the idea is adding things rather than subtracting things.
Thank you so much. And then a follow-up question. So can the barriers experienced by fat body people in accessing care, has that contributed to these COVID-19 outcomes? For example, not accessing care due to traumatic experiences and hospitals not being welcoming spaces, as well as some of the conversation around who is prioritized on a ventilator and some of those things that we also saw, which were tied to fatness.
Yeah, that's a great question. And I think it's an empirical one. I don't think I've seen any research to that effect. And this is one of the devastating effects of BMI, which is that people are so caught up in traditional obesity science. All that they seem to be doing largely is trying to show the relationship between BMI and something else, whereas very serious questions like these are rarely asked. So, I mean, if you are a researcher, I would encourage you to undertake that project. It seems very fruitful. And I think it's the kind of counter obesity science that we need right now.
Thanks so much. Ken, thanks so much for waiting patiently. What's your question?
Well, thanks, Erin. So Dr. Strings, first of all, thank you for your presentation. And I just had a comment. And my comment is, as I reflect on your presentation from a historical perspective, it's not surprising to me that weight was another tool that was utilized to further dehumanize Blacks and to justify the slave trade. And that was something that just really jumped out at me. But again, just another tool to dehumanize and justify the actions that were taking place. So thank you for your presentation. I really enjoyed it.
Thank you so much for your comments, Ken. Actually, that was one of the things that I was really surprised to find in doing this research, which is that there are so many different ways in which they were making distinctions between Black people and white people. I mean, at a certain point, I ran across a theorist whose name escapes me because largely it's been lost to history, who was like, oh, there's 58 differences. And I was like, 58? Like, there's all these dimensions, like, what are you doing? So, I mean, they were just inventing stuff, and they were taking it as gospel. So thank you for your comment.
All right, we have a few more minutes here. We have some folks sharing in the chat some of their own experiences and comments. I'll go ahead and summarize a few. Let's see. So Wendy, as a parent, has shared a little bit about what it's like to have a child who's grown up with the classification of obese, and how the underlying medical issues that were really at play with their child's health were dismissed because conversations continually with providers were really about lifestyle and being admonished to stop eating chips and fast food and all of that sort of rhetoric around there. Here, Wendy, I don't know if you're able to come off of mute, but I sense definitely the concern here as a parent to see your child's health be bypassed and unaddressed for so long. All right, and Scott, who notes that going back to non-white, non-Europeans, who for many biological, economic, and social reasons are, larger or heavier, but are socialized to the idea that thin is beauty and good, and unable to get there, there's a huge impact on their mental health and self-image that just compounds trauma, and then sometimes weight gain, and the circle continues. In fact, a lot of folks reference, the trauma of trying to adhere to a beauty standard and body standard ideal that's driven with these, white supremacist values.
Thank you. Oh, was there someone else who's going to ask a question?
Kobe.
Hey, I was just going to follow up with what you were summarizing as far as some of the comments in the chat. And I think some important or notable comments also include from Leanne asking specific questions regarding substance use habits. Questions such as, do you eat fruits and vegetables every day, or how many days a week do you exercise, and how that would be more meaningful than just a scale with height and weight measurements. And Courtney also added to that mental health, and how that also plays a huge role in the trauma and also in the health outcomes.
Thank you for that, Obina. Hopefully I'm pronouncing your name correctly. And I feel like once I started doing this research, I realized that there is so much more to do. I mean, it's just mind blowing. I think that for the longest time, we assumed that we knew the relationship between weight and health, and that BMI was a good estimation of that, but that's incorrect. And so the kinds of questions that you have presented here are exactly the kinds of questions that we need to further pursue. Why is it that doctors are not focusing more on what people eat and how much they exercise? Or maybe if their family is a family of people who have larger bodies but are completely healthy, or maybe they're a family of people with smaller bodies with a tendency towards diabetes. I can tell you that I'm working on a paper right now in which we're able to show that for Black population specifically, there is a heavy load of diabetes amongst slender persons, right? What can account for that? The existing models do not provide us with any information.
LaShonda, I see your hand raised. Do you have a question or comment?
Sure. No, it's more of a comment. I'm just so excited to hear this information. Like I'm a professional and I've never heard anything to like go against, all this information about BMI. You go to the doctor, BMI. And I think back to my grandmother and great aunties who would always say, girl, don't listen to them white people. We big boned. So just, don't pay attention to what they have to say about this or being too fat. They would just say, this is how we're built. So, you don't be involved or worried about all that. And so now I feel like I have information, some facts and things to take back to people to say, no, it really is true. BMI is not the biggest thing that we should be paying attention to, and that there's so much more to it than that, So I really appreciate all this that you've shared.
Thank you so much for your comments, LaShonda, and also for invoking your grandmother, because so much of the work that I do has been inspired by her. Obviously, I always mention her in every presentation. And I think that the other thing that this highlights is that, so when we were all young, some of us on here are about the same age, I'm assuming, you might remember the song We Are the World, in which it was like the whole world was like, yeah, we need to be concerned about poverty and starvation, you know, especially in Africa, but across the world. And then suddenly it was like, don't be concerned about people who are starving. Be concerned about people who are eating too much. You know, it's like, wait, what? No, we need to, because that is what, that is so typical of what happens, especially in the United States. It's like, don't worry about people who need resources. Worry about trying to shame people who are doing too much, right? So I feel like this is another way in which BMI proves to be a useful tool in a white dominant society. We don't have to care for people who need resources. We should be shaming people who are doing the wrong things with their lives.
All right, Dr. Strings, and with that, we are truly at time. So what a note to end on. Participants, thank you for joining us as well. Dr. Strings, such a pleasure to have you. I'm a huge fan. And thank you as well to our hub team for driving this conversation and moderating it as well. I want to offer a few things to our participants and our team here. Some reminders that our next session will be Thursday, April 14th at 6 p.m. Alaska Standard Time. And we'll be discussing trauma-informed care and the impact of collective race-based trauma on individual health and pathways to collective healing. We had a lot of comments from our participants today about the connection with Dr. Strings' presentation and trauma and as wrought by fat phobia. And I look forward to the conversational arc continuing at our next session. So we hope you certainly attend. That session will feature a didactic presentation by Dr. Tabitha Greer-Reed, psychologist and professor at the University of Minnesota, whose mission includes creating generative, humanizing, and healing spaces for Black students. Again, thank you so much for your participation today and your contributions to building this forum for discussion and learning. We look forward to seeing you next time. And until then, please take care of yourselves and each other. Hub team, if you wouldn't mind joining me in the breakout room for a quick session debrief. And Dr. Strings, you're welcome to join as desired for a brief thanks from our team.
Thank you so much. I think I'm going to have to log off now because it's a little bit later for me. But it's lovely meeting all of you. And yeah, take care and best of luck.
All right. Thank you so much. Have a great evening, folks.